We are back here on Healthy Living. Again, we're with Dr. Craig Boatright, and we're talking about spines, both cervical spine and lumbar spine. It's super fascinating. It's really interesting. We were talking about non-invasive things to do, ways to protect yourself, vulnerable areas. I'd love to talk a little bit about when it's time for a surgical intervention. What can a patient expect? And then kind of what are some of the procedures? You said it's amazing now what you all can do.
Well, and we're very proud of where we are in 2019 with respect to spine surgery because we've come a long way.
I heard you got a fantastic new award also.
We did. The spine unit here at the hospital was awarded by the Joint Commission for Accreditation of Hospitals a spine award basically for being a center of excellence.
Wow. I mean, that's a huge deal.
Yes, that is a big deal, and really, you know what that reflects is the hard work and the attention to detail and the kindness and professionalism that our nurses and our physical therapists and our OR staff and our team and the hospital itself, including everybody from Jeremy, who runs our hospital here as our chief executive officer, down, have put into making this a pleasant, friendly place to come and take care of problems that nobody wants to have.
Exactly.
But that if you do have them, they need to be taken care of efficiently and professionally and with kindness, and that's what we have.
We're excited. After we talk to you, we're also going to talk to some of your other team members who say the same thing. They say it's extremely collaborative, and you can't do one piece without having the other quality care providers right there with you. It's pretty interesting.
There's no better way to think about taking care of somebody in medicine than the fact that it's a team effort. So 100 years ago, it was a team effort. It was led by the doctor, and the doctor was the emperor.
Okay.
But we don't have any emperors in the world anymore, as far as I know, and we don't have. And the doctor's it's no longer like that. And the whole team, and actually the team includes everything from the computer system at the hospital, which is very cold
sophisticated,
to, but more importantly, all the people that are involved with what goes into all that data, and then analyzing the data, and then applying it to take care for you while you're trying to get better from whatever thing is bothering you, and go back to playing golf, where we can turn you back over to that golf guy who gets his computer out and measures your clubs to the millimeter and all that stuff.
Talk to us about some of the procedures that you here at the Spine Center, and you specifically, Dr. Boatright, do and really feel successful.
Well, many of the procedures that we do are the spine. Taking care of the spine is become something that we are doing much more with less invasive means now, and in many ways, the goal of the spine surgery hasn't changed at all. So you either need to have your spine rebuilt or rearranged, or something removed in such a fashion to make it more functional again.
Got it.
And in doing that, 50 years ago, we would make a very big incision on you. We would make you lay in bed for 6 weeks after we did that, and then you'd have to wear a very big brace for another 6 to 12 weeks. So it was a procedure that was hard to get over.
Okay.
In today's world, basically, we use things like hardware and pieces of plastic, and it's all under the skin. You walk the same day of surgery, even the biggest surgeries, and we make sometimes incisions that you can't even see after we've done it. So now, there are things in between. We still have to do some reconstructions where we rebuild the spine over a long distance, and when we do that, we do need to make a bigger incision. But we do a lot of procedures where we make an incision that's small enough you can put a Band-Aid on. I mean, guys like to advertise Band-Aid surgery. I think that's a little. That's a little bit of an advertising ploy, but the thing is, what I would say about it is, some of these procedures that in the past we've made incisions 6 or 8 inches long. Now we make an incision less than a half inch.
Are there some common surgical interventions that you see quite a bit here? In other words, are you doing specific things? I guess I hear things like this is the lay person, they're always dangerous. Fusions or, you know, something with the cervical neck. Are there things that specifically, again, with our aging population, maybe?
We do need to rebuild the spine, and reconstructing the spine frequently requires that we fuse pieces together. People get nervous about the word fusion, but really all it means is that we're just getting two pieces that were previously moving one beside the other to not move one beside the other by having the bone grow. And that can be very important. It's not really scary, but I think 15, 20, 30 years ago, a lot of fusions were done for different reasons than we do them today. And those, and not everybody did as well as they could have. In today's world, we don't do a lot of those operations anymore. And when we do fusion, it's usually because we need to rebuild after taking pressure off the nerves or that type of thing. But we also do many surgeries where we don't need to do a fusion, where we just need to remove something or take something out or rearrange it a little bit, and in those circumstances you don't need a fusion. And those are the ones that we can especially apply these more minimally invasive techniques.
So are you talking about, you say take things out, what's happening to the spine that's going to have me come to you and you say, you know what, we're going to do some surgery, we're going to get this better? What specifically? Well,
after you haven't responded to all those non-operative things that we like for people to do, and it still is a problem for you, or if you're having something where we need to operate right away because your nerve is being injured and may not recover,
that's what I'm asking.
If we don't take care of it, under those circumstances, many times it can be everything from a disc herniation, which everybody understands a disc herniation or a ruptured disc, to it can be cancer. It can be a fracture just from trauma or from not being 18 and your bone density going down as you get older. In all of these things, most of the time though, it's just the degenerative processes that occur with getting older, and it's not related to any specific trauma or even a disc herniation in the population that's older than 55. Now, in younger people, disc herniations are much more frequent, and they can happen at any age. They definitely happen in people over 55, but in people over 55, it's usually the spondylitic changes, which basically means
like arthritis. Yep,
right.
I listened. I got it. Yeah. Talk to me a little bit about disc herniation. I know that that's pretty ubiquitous, and most of us know what it is. But I would like to actually know what causes it and what it would feel like, and how I would even know.
Well,
you'll know.
Many people have disc herniations and they don't have any symptoms. So that's what all the non-operative care that we do. We're trying to take those people who do have symptoms from a disc herniation and put them into the group that don't have symptoms from a disc herniation by doing these various things: physical therapy, injection therapy, bracing, activity modification.
Can I even interrupt at that point? What's a disc?
Well, a disc, this is a disc. So this actually is a picture of a disc herniation. Right here. So this is Slim.
All right,
Slim helps me talk about the spine. And these are the discs, and the discs come between the vertebral bodies. And you can see this actually represents part of the disc that's popped out here. Now I'll have to admit, even though this is an expensive medical model, this is not what a disc herniation really looks like.
All right.
But it's effective because they made it a different color.
Right, you can see it.
And you can see how it could be pushing on this nerve as it comes out of the spine. So that's an effective sort of tool. Now, again, I would say that is not exactly anatomically accurate for most of disc herniations. I mean, you can have one like this, but
for display, it works,
but it does.
Yes.
And you can see how it might push on this, and then what we might do is go in and just basically take out this piece that's pushing on that. In that case, we would leave a lot of the disc in place, and we might do that through an incision that's this big.
See, this is so helpful. I think the visual part of this is really impressive.
Yeah, and you know, many times we're operating where we make a little hole in the back of the canal back here. Again, through a very small incision. In today's world, we might use special retractors or tubes. And generally, when we do these type of things, it's called a micro lumbar discectomy. We use a microscope or a pair of heavy loops and bright light, small bright lights to shine down in there. So my daughter's come to see surgery before, and
it's the best.
She's not very impressed with spine surgery, and the reason is is because many of the things that we do happen through little teeny holes.
Okay.
So if you're trying to watch spine surgery from the edge of the room, you can't see much.
Okay.
It's much better to go see a total joint by Dr. Johnson, or where he makes a reasonable size cut, and you can actually see what's going on from the edge of the room. Because many of the surgeries that we do now happen through a very small incision, and you can't really tell what we're doing from the side of the room.
Can a disc get herniated in the neck also?
Yes, and in fact, just this week, I'm going to do all neck surgery this week. So, and the reason is disc herniations happen in the neck, and when they happen, basically, and of course, this is the back of your skull, and then this would be your face here, and this is the front of your neck.
Got it.
The disc in the neck are here, and they herniate back into the canal, which the canal runs down the back of the structure, and they can push on the spinal cord or the nerve roots, and when they do, you get pain in your arm. Just like when you get a disc herniation like this, it would probably manifest by pain in your leg more even than pain in your back. So pain in the arm and pain in the leg are the things that we treat more often actually than back or neck pain, because back and neck pain don't respond as well to surgical intervention as leg and arm pain do.
Interesting.
But it's leg and arm pain caused by pressure on the nerves.
I really hate it when they tell me the time is up, because just when we get our groove on and going, you have to come back and talk to us again. I think it's something that we're all interested in, because sooner or later, my assumption is we're going to have a little bit of back or neck pain. So thank you for joining us. We want to thank all of you for joining us here on Healthy Living. Please have a wonderful week. Bye-bye.